Good morning, everyone. I am Dr. Chirag KALRA from Deen Dayal Upadhyay Hospital, and I will be presenting a case of cavernous sinus meningioma. Cavernous sinus meningioma is the most common primary cavernous sinus lesion. It can cause a variety of neurological symptoms. Symptoms can include diplopia, ptosis, vision loss, facial numbness due to the involvement of cranial nerve 3, 4, 5, or 6. The diagnosis typically made through MRI. The main treatment options include surgical resection and radiotherapy. So, a 60-year-old female presented to our OPD with headache which was severe in intensity and also with inability to open her right eye, which was gradual in onset and progressive in nature from the past 1 month. Her systemic history included diabetes and history of diabetes and hypertension, for which she was on treatment for the last 8 years. On examination of the right eye, her best rated visual acuity was 6/9. She had a complete ptosis. There were no extraocular movements in any direction. The entire anterior segment had a few nebular corneal opacities. Apart from that, it was mostly normal. The pupils were fixed and non-reactive. The posterior segment was grossly within normal limits. The vitals were stable. Blood glucose levels were controlled. So we sent the patient for neuroimaging, which revealed an intensely enhancing extraaxial lesion in right cavernous sinus, mildly encasing the right internal carotid artery. These findings were suggestive of right cavernous sinus meningioma. These photographs show the extraocular movements. There were no movements in the right eye. This is an MRI scan. Sorry, it's not zoomed in, but it would show a cavernous sinus meningioma on the right side. So what was unique in the case was that these meningiomas usually present with complete ophthalmoplegia, diplopia, and sensory loss. However, severe headache was an important feature in our patient. There are many rare presentations which can be seen in a case of cavernous sinus meningioma, which could help us diagnose the disease at an early stage, because it being a slow indolent, having a slow indolent course, it is imperative to find out the disease at an early stage. So we can alter the management. We can alter at what size the tumor was diagnosed. These presentations include bilateral ophthalmoplegia, isolated involvement of these cranial nerves, third, fourth, fifth, or sixth, endocrine abnormalities if the tumor is pressing on the pituitary, atypical headache as which was seen in our case, or pulsatile tinnitus. So the take-home message would be that cavernous sinus meningioma, being one of the most common tumor affecting cavernous sinus, it is a slow-growing benign tumor that arises from the meninges, and the presenting symptoms depend on the compression of nearby neurovascular structures. Most frequently, they present with diplopia, ophthalmoplegia, ptosis, trigeminal nerve dysfunction, facial numbness, or facial pain. But there can be rare presentations, which we should keep in mind. The treatment options include observation, microsurgical resection, or stereotactic radiosurgery. Thank you.
Nice presentation, Dr. Chirag.
Thank you, ma'am.
What could be the possible other differential diagnosis?
Ma'am, we could have superior orbital Fisher syndrome. We can also have orbital apex syndrome. But in that case, it will usually be painless. It would also not involve the fifth cranial nerve, and it would also, it could involve the nasociliary nerve, but not the rest. And the involvement of second cranial nerve would not be seen in those cases. We can also have other pathologies of the cavernous sinus, like cavernous sinus thrombosis.
And could you comment on what would be the differences in management in catching this disease early versus a late diagnosis?
Ma'am, if we catch it at an early stage where it is operable, then we can remove the tumor. But if it has already penetrated into essential structures, then it is important to we won't be able to remove it by surgery, but rather we would do radiotherapy or gamma knife surgery.
So in your case, which nerves were involved? Like you have mentioned, I was not moving. So what are, yeah.
Ma'am,
So
third, fourth, and sixth cranial nerve were completely involved.
have you checked fourth?
Ma'am, yes, ma'am.
Huh.
Not in isolation, but yes, we checked for all movements, and there was no movement.
So how you check fourth in presence of third nerve palsy?
Ma'am, we asked the patient to adduct and look down.
So patient won't be adducting.
Yes, ma'am.
Okay. So what you will look for?
Ma'am, the eye would be in downward gaze.
You will tell the patient to look down and you will check the torsion.
Okay.
Okay.
How did you check the fifth nerve?
Ma'am, we look for sensations on her face, uh, on the temple area and on the cheek area.
Okay, thank you.
Thank you.